Hello, I would like to thank the ASC leadership for the opportunity to present our work on the impact of pre-hospital triage on postoperative outcomes in acute thoracic aortic conditions. We have nothing to disclose. Acute aortic syndrome is a spectrum of life-threatening conditions involving the thoracic aorta. Timely diagnosis is paramount, and multi-detector CT angiography is the imaging modality of choice. We aim to evaluate how pre-hospital triage and appropriate imaging affect postoperative mortality in these patients. We made a linkage between the Maryland State Inpatient Database and the Emergency Department database. We isolated patients with acute aortic syndrome who underwent emergent procedures on the thoracic aorta. Three scenarios were identified. Group A, patients who were admitted straight to the site of definitive care. Group B, patients who were transferred. And Group C, patients who were initially discharged home, but then were emergently hospitalized. The only significant demographic differences between these three groups were patients' location and income. Baltimore citizens and low-income patients were more often discharged home instead of being transferred for the definitive surgical care. Mortality of patients admitted directly to the tertiary centers was lower compared with the other two scenarios. Any delay in admission to the site of surgery increased in-hospital mortality from 9 to 15%. 60% of patients discharged home were not diagnosed with aortic pathology. Musculoskeletal pain and angina were listed most often. Subsequent mortality was twice as high if aortic pathology was not detected on the prior ED visit. Then we built a regression model to determine predictors of in-hospital mortality. Only patients with prior ED visits were included due to coding limitations of CT angiograms in the inpatient databases. Of all demographic factors, only age above 70 was linked to increased mortality. Transfer from remote counties showed higher mortality but did not reach significance. Notably, the strongest predictor of mortality was failure to obtain a chest CT angiogram during the prior ED visit, which occurred in 19% of such ED encounters and increased mortality from 10 to 25%. Moreover, if CTA was not obtained, median delay in transfer increased from 0 to 1 day, and acute aortic syndrome was diagnosed in the ED only in 19% of patients, compared with 49% if CTA was taken. In Maryland, 51% of surgical admissions for acute aortic syndrome have no prior encounters in other EDs or hospitals, while 40% of such patients are being transferred to the site of surgery, and 9% present from home after evaluation and discharge home. Failure to suspect acute aortic syndrome and obtain a CTA of chest leads to significant delays in operative intervention at the tertiary center and eventually doubles postoperative mortality. Patients' location in the inner city decreases the likelihood of transfer. Borderline increase in mortality in the rural population is likely multifactorial. There were no significant associations between patients' location and failure to obtain CTA, or misdiagnosis of acute aortic syndrome, or delay in transfer. I was asked why the delay of 1 day or greater did not demonstrate a significant increase in postoperative mortality. The delay in transfer to the site of definitive care was strongly associated with absence of CT scan, and therefore the delay did not reach statistical significance as an independent predictor. More specifically, if CTA was obtained during the preceding ED visit, then there was some delay in transfer in 30% of patients, compared to 57% when CTA was not obtained. Additionally, patients were taken to the OR earlier if aortic pathology was detected on prior ED visit, on day 0 in 60% if diagnosis was established in the ED, compared to 48% on day 0 if acute aortic syndrome was not suspected. So we should probably emphasize time to the OR instead of time to the admission to the site of surgery. Thank you.